get clients who get an adult onset of psoriasis and eczema. And we may, as skin therapists, be the first, I guess, port of call. They may show us their skin concern first and say, hey, what's this? What is this that I've got going on in my skin? So that's why it's so important to really invest in our education as a professional skin therapist and understand how these conditions differ. So we're going to jump straight on in, and I wanted to begin with the sort of like differences but similarities in this psoriasis and eczema condition. It's interesting, when we think of psoriasis, we often think of that classic thickened skin, but in some cases, there are 5 different types of psoriasis. Some can look actually like eczema. And on the flip side, eczema, there are some forms of it which can actually look a little bit like psoriasis. So that's where we felt the need to present on this topic today. So let's begin with the definition of psoriasis. And you can see right here, we've got this pinky purpley base with the white thickened plaques that have built up on top. And one thing I know is that we've got a vast clientele of various different skin ethnicities. And if we have a client who has a melanin-rich skin, we may notice this skin condition may present with a slightly darker purple inflamed base, but we will see these thickened plaques of skin built up in a shade of white or grey. But it is a chronic inflammatory multi-system disease, and it is characterised by these painful, quite often painful, more so than itchy, which is a difference in eczema, raised plaques of skin. And it can not only just affect the body, but sometimes we may find it affect places like the nails, on the toes and the fingers, also too in the scalp. So it can be a full body skin condition, as is eczema. And when we're taking a look at eczema, we know that it is a term which encompasses a group of inflammatory skin conditions. But typically with eczema, we will see a skin that's very dry. That's a definite, we see the dryness in the skin. It can become scaly, then itchy, and then become inflamed. Obviously, in the skin, we'll see tones of a purple-brown colour in this melanin-rich client that you can see right here. Sometimes you can see blisters and the rash form. And in a less melanin-rich skin, in a fair skin complexion, it'll be a pink to a red colour, but always dry, scaly and itchy. So who actually gets these skin conditions? So it's quite interesting. When we're looking at psoriasis, 1 to 3% of the world's population actually suffer with it. In America, it's 1.4 to 4.6%, UK 2 to 3%, and Australia 2.3 to 6.6%, which is quite high. It can affect both men and women, and it commonly comes in the ages of 15 to 35, but it can also onset at 50 to 60 years of age. 75% of sufferers, though, get it by the time that they turn 40. And it seems to be a condition more common in Caucasian skin than in other races. Looking at eczema on the flip side, this can affect 10% of adults, 20% of children, both male and female. Though interestingly, it's been said that the link with testosterone, which is more dominant in men, means that they tend to have worse or more incidence of eczema than a female does. It's because of testosterone delaying the recovery of the barrier function. So I thought that was interesting to share with you. I loved it. I thought you would too. It also tends to be something that by age of 1, 65% of children will have had it. And then by the age of 5, 90% of eczema sufferers will have it onset into those early years. But it's funny, the skin can grow out of it. You can become an adult that is eczema free. However, as we said, 10% of adults can still suffer with eczema. It's more prominent in more developed countries because of more exposure to chemicals and also to pollution. But as I said, sometimes it can disappear. But when we're looking at eczema, it does encompass many different skin conditions, though atopic eczema, which is mostly what we're referring to today, your clients will be finding they can be prone to hay fever as well as asthma. And it's known as the atopic triad when they suffer with the eczema as well. Psoriasis has other comorbidities, not so much with hay fever and with asthma. They tend to have heart conditions, diabetes, prone to depression and also obesity. So there are some quite unique, comorbidities with each of these. So taking a look at what on earth is going on in the skin, well, we thought we'd start with psoriasis. And psoriasis is a malfunctioning basically of the immune system, and it is also with eczema. But where it goes wrong in a psoriasis sufferer is the person has problems with their T cells. It's actually nicknamed T cell mediated disease. And what happens, these T cells that normally go about their life in the dermis, in our body, fighting infections, keeping us safe, they end up somehow in the epidermis. And when they reach the epidermis, they release cytokines, specialized cytokines called interleukin 17 and 23. Interleukin actually means a cytokine specific that only white blood cells use to communicate with each other. Fascinating, right? And the 17 and 23, they actually target the receptors on the cells, and they cause that keratinocyte to hyperproliferate, produce absolutely, huge volumes of skin cells, which instead of taking 28 to 35 days to reach the surface, they reach it in 2 to 6 days. And then once they get there, they don't fall off. You can imagine those cells aren't formed correctly by the appearance of psoriasis in the skin, but these cells stack up to form plaques. They also, because of the attack on the keratinocytes, the skin underneath that area will become inflamed with the hallmark purpley pink underlying color under the skin. So that's what's actually going on, though scientists actually say they don't know why it happens. All they know is it's genetic, and it's when both parents have this gene that causes this malfunction in the skin. Eczema is quite complex. Now, we're not getting an attack on the cells as we are in a psoriasis skin. However, we have a lot of cell mutations and genetic malfunctions. And a lot of it is surrounding a impaired barrier function. And we've got compromised lipids because of one, the ceramide gene, of which is responsible for producing 50% of the barrier lipids in the epidermis, in the corneum. And that ceramide helps to bind those lipids to the skin, keep the skin watertight, and trap the NMF, which is the moisture factor we know of, which is made up of water, hyaluronic acid, urea, and a host of other agents derived from filaggrin. We'll talk about that in a moment. But the ceramide, when we don't have great barrier lipids, it causes the moisture to evaporate from the cell, giving way to an extremely dehydrated skin condition. And a faulty barrier means that many antigens penetrate the skin and activate the immune response. And that causes the skin to be in a constant state of battle. And inflammation will obviously be a result of that. Now, we also have another damaged gene, and it's the filaggrin gene, also known as filaggrin, depending on where you're from. But filaggrin is the largest protein molecule in the skin, and it has two jobs. First of all, in the granulosome, it takes all the keratin. Imagine all of your pieces of paper, you know, from your workbook, your student notes, are all little pieces of paper, sort of like everywhere in the skin, in the granulosum. Imagine I'm like filigree and I stack these all together to make a really nice, neat stack of keratin. I'm going to hold that tight till I get up to the corneum and then lay them out neatly stacked in the skin, allowing for a great functional, healthy cell to form that can desquamate properly. My job now as filaggrin, if you can imagine, I'm going to click my fingers and melt like the Wicked Witch of the West from the Wizard of Oz to form the NMF. Now, there is a gene fault on the filaggrin gene, and it doesn't stack the keratin properly, and the skin cells in eczema look and appear quite crumbly. And because the filaggrin isn't formed properly, there's not much moisture factor in the cell to retain moisture and allow the skin to work properly. It also affects the pH of the skin. And instead of 4.5 to 5.5, the pH will rise to 7.3 to 7.4. It causes a shift in an enzyme, serine protease, that breaks the desmosomes in the corneum to allow the skin cells to shed. What actually happens is they go into crazy mode, hyperactive, and they begin to make too many skin cells shed away, and it causes the skin to thin. This will then cause a disruption of the microbiome, particularly Staphylococcus aureus, which loves an alkaline environment and a weakened skin. It has no problem at all going into those breaks in the skin and causing infections. In fact, it's very well known eczema sufferers, especially children, are prone to cold sore, school sores, impetigo, adults, boils. Another challenge is hidradenitis suppurativa. It's an awful, inflamed, almost like a boil that forms in the armpits and around the groin, and it is a deep staphylococcal infection inside the sweat glands. Awful. And that is something that is definitely a link to eczema sufferers. They also have high immunoglobulin E antibody, which is a highly reactive antibody that is sensitive to pollen, dust mites, and also to a host of other challenges in the skin, especially, insects. So you'll find that people with eczema have high allergies. Now, the interleukins that are secreted in eczema are different to psoriasis. They are 4 and 13, which cause a whole heap of inflammation in the skin, and 31 causes itch. So these are identifying these numbers is important to understand how medication works, because medication for eczema and psoriasis focus on the specific interleukins. We'll talk about that briefly at the end. And these skins are prone to ichthyosis vulgaris, which is that fish scale skin, very, very dry. So these clients may say to you, I am so dry, what can I do? So reaching out for your phyto-replenishing body oil, mixing it with the body hydrating cream is definitely something which makes a massive impact on the skin. So let's take a look at our next port of call, and that's just some new information I found out in terms of another reason why people get these conditions. And I recently discovered in the American Academy of Dermatology, but then also too, the University of Arizona have done a whole lot of research on the microbiome of the gut and also the incidence of these conditions. And it was shown that in psoriasis that the patient, I guess, has a lower richness of the diversity of the microbiome colonies in their stomach. And that can, and in comparison to people without psoriasis, there was a massive difference. And that was felt to be a trigger that could also be causing the psoriasis condition to flare. And also dysbiosis in eczema are dysbiosis of a overriding sort of colony of pathogenic microbes, so bad bacteria, versus the good microbes. And studies have been conducted to show that by taking probiotics can actually really help, particularly if you're using lactobacillus and bifidobacteria probiotics. So these are just things I thought I'd share with you. That is where the future is moving to with treatment. and prevention. So let's take a look now at how to identify these skin conditions. And I wanted to start us off by talking about the psoriasis. Now, there are 5 different forms of psoriasis, but there also can be a incidence of arthritis with this. So we've got the plaque psoriasis, which is typically the vulgaris we see commonly, guttate, pustular, inverse pustular, and also erythrodermic. So let's go straight in to the most common form of psoriasis, and that is the plaque psoriasis. You can see from the screen that we've got that classic sort of inflamed base with the thickened plaques of skin cells on top of the skin, often affecting the elbows, the knees, the scalp, on the body, sometimes in other areas. But we can see that skin would become very, very itchy, irritated. It can feel painful, and that's a hallmark of psoriasis. People say it hurts, and it can bleed and crack. So this is the most common one that we will see in our clients who present with psoriasis. Another very common form is guttate. Obviously, it's not as common as the other. It's about 10% of psoriasis sufferers are affected by this type. But after a streptococcal infection, often strep throat, or another infection in the body, young adults and children can experience this, and it tends to affect the trunk, the arms, and the legs. So it can start as other forms of psoriasis, but this is something that we may see coming in, given we have, had a lot of illness of late around the world. So just something to be mindful of. This can actually come as a once-off and disappear completely. But in some people, they may continue to suffer with this. So you would just hope for the, fact that would go away in the skin. The next one I wanted to take a look into is the pustular psoriasis, which presents in 2 forms, generalized and localized. Around about 5% of psoriasis sufferers will experience this form. It's mainly in adults, and it is something which can come on from sunburn and infection, medications like lithium, which is a psychology medication to help with depression and bipolar and other forms of mental illness, cortisone, but also too a sudden cease. So when a person has taken themselves off a medication suddenly, or even fallen pregnant, this can cause the onset of the pustular psoriasis. On the image, this is the generalized. It's very severe, isn't it? Take a look at the redness, the scaling, the thickening. It almost looks like the skin's been sunburned and it's peeling. It doesn't look like the classic psoriasis that we are so used to. Let's take a look at the localized form, which is also known as pustular psoriasis or palmoplantar psoriasis. And take a look at the hands. It is a red, swollen, cracked, thickened skin condition. It can present also with that purple to brown in your clients who may be more melanin rich. It begins as dot-sized, pencil eraser size pustules on the skin that begin to form pus and also start to thicken in the skin. You can imagine the pain that person will be in when they walk and when they use their hands. So we may see this as a condition come in through our doors. Inverse pustular is a more uncommon form. It is severe and quite incapacitating, but this is a form which tends to affect the folds. So armpits, the genital area, buttocks, under the breast area. And you can see it doesn't really look like general psoriasis would. We've got the red inflamed or purpley inflamed base that is much more smooth and shiny. Doesn't have the thickened buildup of skin, and it becomes irritated from friction and sweat. People who are overweight tend to be more commonly affected by this, obviously because of the fold in the skin and the trapping of sweat. They may suffer psoriasis elsewhere on the body, but this could be exclusive. So be on the lookout for that. If your client is having body services or waxing, you may notice this that thickened skin, that rash. It may not just be a sweat rash. It could possibly be a form of psoriasis. Now, from here, there is a much more severe, very rare form of psoriasis, which is often called exfoliative or erythrodermic psoriasis. And this is severe redness and shedding of the skin, covering a very large portion where the skin appears to be burned. It's very itchy and painful, and it can cause fluctuations with your body temperature. So with that, it's quite a challenge for the person's health. They may have accelerated heart rate due to the increase of flow of blood to the skin. So this person would definitely be under a doctor's care, and I'd be very hesitant to with my treatments, I would definitely want to keep in contact with that dermatologist about what to and not to do for that client's skin. But home care would be essential. It would just be interesting to see what the doctor would feel is most important for that person. Now, something that happens to 20% of psoriasis sufferers is that they can be affected by arthritis, and it's called psoriatic arthritis. And it's not affecting the skin, but the joints, the cartilage of the body, and it will cause pain, swelling, tenderness, even stiffness in the joints. And it can affect, the whole body, including the hands and feet. Your skin can be quite red and hot and warm to the touch and cause almost like sausage-like appearance to the fingers, pain in the Achilles as well, and the person may be prone to plantar fasciitis. So something, if you have clients ever say, I just get such bad arthritis, it's just interesting, if you see they have psoriasis, that is the link. And the final one to take a glimpse into is the acrodermatitis continua of Halepo. That's a big one. But this is where the thumb and the nails on the body can be affected by these sort of pustular lesions that can accompany the arthritis. Can be difficult to treat, but just be mindful of that. If you were to do any nail service, if you see that, it could be a form of psoriasis. So just something I wanted to bring up is the Psoriasis Area Severity Index is a tool that the dermatologists use to diagnose whether somebody has a mild, medium, or a severe form of psoriasis. And it's called the hand test. So the hand makes up 1% of the body surface. So depending on if you've got, 3 areas, we've got less than 3% considered mild, 3 to 10 a moderate, and 10% is considered to be severe form of psoriasis. And that also helps determine the treatment from doctors and dermatologists. But just something I thought, in case a client ever says to you, I've got a PASI or a PASI of moderate psoriasis, you know what they're talking about. Now, eczema we're going to jump into now. There are many different forms. I used a lot of my research from the National Eczema and Psoriasis Society in America and the UK and Australia for the presentation. And there are many, many different forms, but these are the 7 forms that they speak of in this particular forum. So the first one we wanted to take a look at is the atopic versus non-atopic eczema. Atopic eczema, as we've talked about already today, is the skin condition where we've got higher immunoglobulin levels in that person, high reactivity, asthma, hay fever, and eczema they tend to suffer from, which is the atopic triad. And you'll find this occurs in the folds, the creases of the body, inside the elbow, behind the knees, the neck, the eyelids. And this is common in atopics, and they have the allergies to many different foods as well. Non-atopic dermatitis is where somebody doesn't have high immunoglobulin E levels. They may not even be affected by hay fever and asthma, but they have this red inflamed rash on the skin where their barrier has been damaged. So as a skin therapist, we may see this if a client has overused a retinol in their skin, for example, a person has overused an exfoliant. Maybe they have a piece of jewelry which could cause them to have this injury to the skin. And on the next slide, I've got some other pictures to show you where a person has had a contact dermatitis come from nickel, from other metals, from hair color, and that's caused that contact dermatitis. That person over time, if they continue to be exposed to that trigger, could develop an allergic contact dermatitis to that there. Now, the next one I wanted to share with you is commonly seen in a lot of our clients. It's seborrheic dermatitis, and this is an overgrowth of a yeast called Malassezia. And this yeast, when it becomes in a higher level, the body starts to react to it, and it causes this red inflammatory condition. Quite often, it's the side of the nose, in the eyebrows and ears, but it can also affect the scalp in adults and the scalp of babies with the term cradle cap. We may have seen that before in either your own children or in other children that you may have come across. Nodular dermatitis around discs, often known as discoid dermatitis, and it can often affect the lower legs in elderly people. And it can just occur possibly because of circulation challenges and maybe other things. There's not a lot of information available, like stasis dermatitis. This is where a person has faulty valves in their veins, where they start to have leakage of blood out into the surrounding areas as well as lymph. And what happens is they start to develop inflammation in the skin, and a dermatitis rash can occur as well. The problem with this, especially as it is a more elderly patient concern, is that they can get ulcers that take a long time to heal. So something worth noting. Now, the final two is the dyshydrotic dermatitis, which is little blisters all over the fingers and toes. And this can occur from damage to the skin from a chemical, also sometimes from medication. And neurodermatitis, don't you see how much this looks similar to psoriasis? This is actually where the skin thickens because of constant friction of scratching. So if you have a person who is terribly, that habit of scratching, they just can't stop, it can actually turn into neurodermatitis. So all of these forms of dermatitis quite often will be under the care of a doctor. But what we need to understand when we're giving our clients advice is, what are the triggers? What can cause the skin to flare? With psoriasis, it can be stress, same with eczema. Definitely stress is a big trigger. Illness, stress infections, injury to the skin, falling over, grazing the skin. Certain foods can bring it up, and foods for psoriasis are gluten, beer has been shown. Alcohol's not great for psoriasis, but beer especially because of the yeast and the hops. Eggplant, white starchy potato, strawberries, tomato, even some dairy and shellfish. Pork, red meat need to be eaten in moderation. Reducing sugar is important, and also try not to have fatty foods because they can all trigger off challenges in the skin. Certain medications can also bring it on too, high blood pressure, antimalarials, lithium, which is the mental health medication, and also rapid withdrawal of steroids can all bring this through. The smoking is a trigger. Interestingly enough, as is excessive sun exposure. However, having small bouts of sun exposure is actually very supportive for psoriasis. It's just a matter of knowing when to stop. Cold climates, dry weather, obesity, these can all be challenges that bring on psoriasis and trigger, worsen it, flare it up. Eczema, psychological stress, but it's a high humidity, low humidity, the cat hair, other dust, pollens in the air, even sweat. Sweat can be a big trigger. So, sometimes people can't avoid sweating depending on where they live, but having help trying to get rid of that sweat quickly. Short showers, not hot baths, because baths can take away the barrier lipids because they're water soluble. Ensuring they're not using alkaline soaps. Diet, things like wheat, lactose, eggs can be a challenge for eczema and cause triggers in the skin. And certainly fragrance. And it's not just fragrance that you spray, not that you should spray it on your neck, as we know, but it's the fragrance in your fabric softener. What washing powder do you use? And there's a lot of fabric brands now, laundry liquids, that make it completely fragrance-free, which is excellent and essential if you're an eczema sufferer. Ingredients that need to be avoided. This is our real realm here. It's important that even though psoriasis and eczema at times can be quite thickened, we have to avoid harsh abrasives because they can actually get in and cause infections, especially in psoriasis. Gentle powders that are mixed with water form a creamy paste. They're okay, but definitely not particles of, seeds and that can irritate the skin. SD alcohol is inflammatory, as is menthol and fragrance. Soap is irritating. Going for a body wash that's 4.5 to 5.5 is essential, and backed up with wonderful essential oils that purify the skin and control the staphylococcus. Conditioning body wash is brilliant for the skin as an alternative. Chemical sunscreens can really flare up these conditions, so looking for a physical sunscreen, invisible physical defense for the skin, is very much indicated. In terms of what to look for, ingredients is something that can really be supportive and keep those skins in remission. So anything with oat and Avita sativa is your best bet. It's a clinical US pharmacopoeia grade that is extremely powerful in its antihistamine and barrier replenishing functionality. Lactic and salicylic acid are fine for both skins, but you just need to be aware that the person isn't taking the D3 calcipronine medication, because salicylic acid is contraindicated. It would be something I would check with the dermatologist though, because it may be the percentage of salicylic acid. So something to investigate with the doctor. Papain, enzymes that eat through the skin cells, zinc pyrithione and selenium. Selsun blue, selenium sulfide, is excellent for seborrheic dermatitis that the person can be affected by. Plant oils are brilliant. Phyto oils, coconut, safflower, evening primrose oil. Also too, looking in at kukui nut oil, chia seed, Camellia japonica oils, wild Thai orchid. All of those plant oils are brilliant for helping to restore the essential fatty acids in the skin. Safflower oil, I must call out, because it is a ceramide donator, and we know that there is a ceramide deficiency, particularly in a eczema-prone skin. Saccharide isomerate is a moisture magnet, and it's been formulated in a lot of recent formulations, and this holds and binds water to the skin. Hyaluronic acid, we know that that is brilliant for hydration, but something that's a little different is atomized sea salt. This is sea salt, salt water that's been spray dried, and it causes the salt molecules to become extremely concentrated. So what we find in that is magnesium, potassium and sodium, but most importantly, magnesium. There's 70% more magnesium in atomized sea salt than there is in ocean water. And it is excellent for helping to remineralize the skin. So it's not actually in an abrasive form, it's in a it's put into a product, and you don't even notice that the salt is basically something you can feel. So very good for skin health. And then two wonderful silicons that are not occlusive silicons. Some brands, the silicons aren't as great a quality, but cyclopentasiloxane and dimethicone are fantastic quality that allow the skin to still function as it should, but it really helps to sort of fake and mimic those barrier lipids while the body is trying desperately to make them. So those ingredients are a definite call out. And as you may all know, the International Dermal Institute is the birthplace of Dermalogica. And I just felt I would pop up a few solutions from Dermalogica that really help. Obviously, whether a person is in a completely inflamed state or not, whether it's affecting the face or not, we can definitely lean in on these. So Daily Milk Foliant, what a fantastic formulation, contains a lot of those key ingredients that are supportive to the skin. Daily Microfoliant is also another which can be used. Ultra Calming Cleanser is brilliant when the face, especially with eczema, is flaring or the psoriasis may affect the face. Ultra Calming Mist, beautifully soothing antihistamine sprayed on the body. It's great for psoriasis all over the body to help take out some of that itch, but also to the eczema. Following on with the moisturizer, Calm Water Gel is beautiful, hydrating and cooling. Barrier repair will restore the skin's barrier, as we know. Hyaluronic ceramide mist, it's got 2 call out ingredients in the name alone that you can see the connection now as to how it would be very supportive for the skin. Invisible physical defense. Also, something which is a little off the sort of thought, but rapid reveal peel is fine when the skin isn't in a flared up form of eczema. It can be used to help with that dryness and the dead skin buildup, especially with psoriasis. And on the body, leaning in on Phyto Replenish Body Oil, the conditioning body wash, they can work incredibly to help and support the skin, along with the body hydrating cream with its hydroxy acids. So when we are actually doing a consultation with our client, because they're intending to have a skin treatment, we certainly can help that client with an incredible treatment. But there are a few things that you want to touch on in your consultation, you know, from medical history, any medications they're taking. And when I bring up medication in a moment, you'll see that there are some that you may recognize and be mindful of. Also too, you want to ask, what are your stress levels? Because stress does inflame the skin condition. Infection history they have, boils, the hidradenitis suppurativa, if they're underarm waxing or having laser services, we want to ask about that. Itching, burning sensations. Also, we may notice food intolerances. Or ask the client, I will ask them, are you prone to hay fever or eczema? And because then you know that they're atopic and will suffer with high sensitivities and allergies, especially if they say to you, I'm very sensitive, be careful of my skin. And home care, we certainly want to find out what they're using on their skin to help, because that could be also another trigger that may be inflaming their skin. So in a treatment, we can do a great treatment with our double cleansing, softening up those plaques. I wouldn't hesitate to use a resurfacing cleanser if the skin doesn't have breaks or fissures in it. Obviously, pre-cleansing the skin with the oil is wonderful. Going ahead with our analysis and really taking a close look at how that skin is performing and looking out for post-inflammatory pigment, because they're 2 big challenges with these. You may be treating them for post-inflammatory pigment as well. So we can exfoliate, just enzymes, light exfoliation if they're inflamed, but hydroxy acids are okay, just using obviously something like Accelerator 35 in a smaller amount of time, or even mixing it, something like Daily Milk Foliant for the extra calming effects on the skin. Touch therapy, we definitely want to reach out with our touch to reduce stress. And we've got many forms you can learn, especially the International Dermal Institute, from reflexology, stress therapies, right through to pressure point and lymphatic drainage. Serums on the skin, ultra calming serum concentrate is incredible, reducing redness and inflammation by up to 21%. It's excellent. And clinical oatmeal mask is brilliant. But if you have LED, the near infrared, also red light, can be really supportive to that inflamed, pain, itchy, irritated skin. and then layering on dermal layering with mist and serum. Ultra calming is going to be the way to go, and certainly finish with a prescription, a little or a lot, depending on what they need, and that will help to ensure the home care is carried through. But just be very mindful if somebody suffers with psoriasis, not to injure the skin with our micro injury treatments. Micro needling, you would just need to check in with your supplier of nano needling, because it doesn't puncture the skin, but just whether it does count as an injury to the skin, you would want to get that double checked. Cosmetic tattoos, brows, eyeliner, lip liner, it's a no-go. Also, radio frequency, especially nanofractional, because it's ablating the skin. Injectables, waxing over plaques, we can't do. Too much heat and stimulation can be a little aggressive on the skin, and certainly, obviously, really harsh, abrasive exfoliation. So keep those things in mind when you're designing your treatment plans with these clients. Now, in terms of treatment, medically, these people will need to be under a doctor's care. And for psoriasis, topical and systemic medications may be administered. So for the topical applied, it's generally corticosteroids, vitamin D3, calcipotriene inhibitors. The one I mentioned you need to be mindful of with salicylic acid. So maybe screenshot that one, keep that in mind. Coal tar is often advised, along with tea tree bark, with its extracts of anthralin, which can help slow cell production. Topical retinoids can also help to reduce the size of the patches in psoriasis. So it's not uncommon to also have retinoids combined with corticosteroids. Systemically, JAK inhibitors can be swallowed. This is a new form of research. There's a lot of information on the National Rosacea Society. I suggest you have a look at. It's really interesting. But these JAK inhibitors, they actually inhibit interleukin 17 and 23, and they are oral. Injected medication, systemic, is biologics, or biosimilars, which are like a generic form of biologics. They're a lot cheaper and more accessible. But these actually target the specific parts of the immune system, like the receptors and also the actual interleukins, and helps to block that disease. And they can give great respite for the skin. Immunosuppressive therapy can be taken, retinoids, along as well for the skin, antihistamines and antibiotics. So these are common. Along with light therapies for psoriasis, you may have heard of the UVB light therapy, or PUVA, which is combining a light, sort of like a sensitizing medication called psoralen. It's applied to the skin, and then the skin is exposed to these UV lamps. And what that does is it helps to put the skin into a remission, anywhere from 3 to 6 months, depending on how well the person responds to it. There is also a more specific laser therapy called the eczema laser, where they can use more like a torch and a smaller area just to target the small patches of psoriasis. Because obviously light therapy over time, it can have the trigger of some skin cancers. So something to be, obviously a dermatologist will be very mindful of what sort of treatment this patient is receiving. For eczema, topicals are generally the corticosteroids to really help to modify the immune system, attacking on the skin constantly, and also switching off the itch. Antibiotics are often topically applied, like your Bactroban, for the school sores and also the boils. JAK inhibitors, last year, 2021, the ruxolitinib, which is a topically applied JAK inhibitor, was deemed safe by the FDA. So that's something which doesn't have to be swallowed, ingested, just applied locally on the area. And emollients are always prescribed for the treatment of eczema. Systemic, swallowing the tablet JAK inhibitors for interleukin 4, 13 and 31 can make a massive impact on the skin, along with immunosuppressive therapies, antibiotics and antihistamines. There is also biologics available and biosimilars to target specific parts of the immune system, blocking those pathways of disease. So these are the common treatments that are often medically advised. You may notice on the consultation card that a client may say a certain medication. I always like to have my phone handy so I can do a quick, what is, JAK inhibitor, ruxolitinib used for? And that way it gives you an idea, and it would be important for that client to contact their doctor to run the treatment past, or also share their number with you so you can speak to them directly about treatment plan that you would like to do on the client. Because as we know, they may only suffer these conditions on their body, but they'd like to have skin treatments. So we just want to make sure that no medication is contraindicated to light therapies, our needling, peels, and any other services that we would hope to be able to do. So as a nutshell, in finale, I guess, of our webinar today, things you can suggest a client do is keep a diary of those triggers. We want that person to take note of what changed that day. How did they feel? What did they eat? We want to also reduce stress. We want to talk to them about, meditation or something that they do that takes their mind away from their skin condition. Don't pick. Stop, avoid over scrubbing it, using harsh loofahs on the skin. Moisturize, 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 and ensure the client has a good quality moisturizer free of ingredients that can cause other irritation, particularly lanolin and mineral oil-based creams. Increase that exfoliation with something gentle. Limited UV exposure, daily warm baths, particularly for psoriasis, and keeping showers short for eczema. And also stress relieving treatments by you as the skin therapist. So these will all help support you so much. And most importantly, I would say, I've really, condensed a lot of the research that I've done into this 45 minutes. But by reaching out to the organisations I've got on the screen right here, the Eczema Association of Australasia, National Eczema Society, National Psoriasis Foundation, and certainly the National Eczema Association, you can get lots of great information, everything from bleach baths for eczema, treatment for babies, right through to geriatric care, and everything in between. But I am just really hoping that you've enjoyed today. And I know Cecile's going to come back on. We invited you to put any questions that you have. We were hoping you pop it in the chat. If you've got questions now, do enter them and we'll be able to get to those. So Cecile, would you like to join me?
Hi. That was amazing. So much information, and everybody is commenting that they had such an informative 45 minutes with you. We did have a few questions. We had somebody asking if they are able to have both psoriasis and eczema at the same time. I think they may have it, in certain parts of their body. And is that something that's possible?
It is possible. I have read in my research that some people can be unfortunate to suffer with both. And that would obviously be a very complicated form of treatment. I'm just thinking about, topicals and oral and injected. It would be that would be a definite balancing act. But there's a couple of great webinars on the National Eczema Society or Foundation, the American website, that actually has a video of a doctor, a dermatologist, who talks about how they can also get certain JAK inhibitors that have all of those interleukins that can be targeted. So there is hope, but it would be very complex. Can you imagine?
Yes, definitely something to really go through with their doctor. So we have another person that is asking, is there any truth to baby wipes can cause, because they've read the preservative in them is causing an allergic reaction?
You know what, I wouldn't rule it out. And also something we have to be mindful of baby wipes is sometimes they contain solvents, which may be also damaging the skin's barrier function. So that could definitely be it. In the preservatives and even fragrance. A lot of people don't realize baby wipes can be so injurious to the skin. So I would definitely say to them, maybe looking at face cloths that they just use water to wipe the skin. That would be something that I would definitely suggest.
Yeah, I believe that here in the US, we have types of baby wipes that are like water only type of wipes. So maybe look into those if you're, you know, having a reaction from some of those other ones that may have preservatives.
Yeah.
Something centering on more of a treatment. Someone is asking about if people with minimal eczema are okay to get microdermabrasion done.
Yeah, I think that would be fine. And it would come back to, how does the skin's barrier function look? I think about clients that I've had over the years when their skin's been in remission and the eczema has kind of gone down, though they do have more of a sensitive skin, just on low pressure, microdermabrasion has been actually quite good on their skin. It is ideal to go ahead more so with chemical exfoliation, just because sometimes friction on the skin can inflame eczema. But if their skin is looking strong, and you feel it would stand up to that, then that could definitely be done, but just not when their skin's flared, which I know you wouldn't be wanting to do anyway. But that would be my response. Yeah.
Yes. Okay, great. Let's see. Somebody is saying that they have slight eczema and allergies, but not asthma. And you have to have all three to be considered in the atopic triad.
Yeah, that's it. I actually can relate to this one because that's me. I was a kid who screamed as a baby. My mum said I didn't sleep for 2 years, so I feel for her. But I didn't have asthma, but I had terrible hay fever and also the typical atopic eczema, which I've grown out of as a adult. So if you do have two, you can actually still be considered an atopic. From my research. So yes, and you probably, and quite often the skin will be that thinner, finer skin, maybe lighter hair. My hair is faking it. It is darker, but it is more of like a lighter brown with a gingery look to it. Not certainly don't have red hair. You can see by my eyebrows, but yeah, but that could be the case.
Okay, great. Yeah, I also had, my kids when they were younger also had issue with eczema. And we were just at the end of our rope. So knowing what happens and what may cause it and things to look for is really super helpful for everyone, I'm sure.
Mm.
And here's a question about the most effective at-home exfoliant for psoriasis, seeing as it would need to be used more frequently.
Yeah. And, when I think about that, if the person is if this a colleague on the call is a dermatologic stockist, rapid reveal peel, I would be very confident with that because, exfoliation, you could use superfoliant, and the particles in it, obviously with water, they really kind of like soften and bloom. And they would be able to be rinsed away quite easily. That could be something. Rapid reveal peel, I would be comfortable with that. I'm not quite sure about the multivitamin thermofoliant. I think it could be just a little bit too gritty and getting in there, whereas at least the powder foliants are more sort of soften and bloom and form that paste, and you can also control a bit more water. But that would be something, and maybe having a chat to their doctor about maybe something they can do just to help eliminate the plaques. It's almost like you kind of want to help it from the outside, but the problem is so from the inside, causing that crazy, reproduction of skin cells. But the hydroxy acids would be, in those products, body hydrating cream, it's very mild, but it would be effective. But especially, I think, rapid reveal peel. Yeah.
Okay, I think you might have addressed this during the actual presentation, but about red or blue light being more beneficial.
Yeah, because in terms of eczema, we know that the Staphylococcus aureus species can actually become quite quite high. I know with the blue light, in my research, it's been really focused around the QT bacterium, that used to be called the P. acne. So whether it has the same effect on the strep or the Staphylococcus aureus, I'm not quite sure, but definitely I'm thinking the red for its ability to help with the immune system and help with recovery of the skin. And near infrared is also wonderful because it really helps with, wound healing. I've had a lot of experience with that myself with a nasty spider bite I had a few years ago. Near infrared was what really helped the ulceration. It wasn't pretty, but it can be very good for wound healing. And I think in affecting both psoriasis and eczema, red and near infrared would be my pick.
Okay, great. And I'm just going to pick one more out of some of the questions that we were getting about electricals that are best for these conditions, like in treatments.
Yeah. And I really think things like microcurrent ultrasound, they're actually quite good. So I know a lot of therapists really love their microcurrent, especially the handheld devices, what you can use the blade down flat, sliding along the skin, infusing those key ingredients and masks. I would definitely be a fan of that, even just gently scraping against the skin for their eczema, if they're, obviously on the face. Psoriasis, gently, it could be something that could be assistant. Obviously, you don't want to scrape at it hard because you would hate to lift it and cause the skin to break and bleed. But I think also too, galvanic, if anybody has that equipment, and just plain ultrasound, I think that would be fine. In terms of diamond polar radio frequency, I'm just not sure if that would generate, it would be too hot because often the skin can reach up over 40 degrees Celsius, and in Fahrenheit, that's quite high. That's a summer's day in Australia is 40 degrees Celsius. So Fahrenheit, I'm sure it would be way up there, too much for a inflammatory skin condition. Hydrodermabrasion you could get away with. I think, the water makes the skin slide nicely and cools and soothes the skin. I think that would be another piece of equipment that I would, feel quite comfortable with on the skin for those conditions.
Great. So we are getting to the end of our time together, and I know there are some other questions that people might have regarding this topic. I would encourage you to stay tuned on dermalinstitute.com, and that we will be posting a recording of this webinar there. We don't generally have notes included with our webinars, but in the future, please continue to check out some of the classes that we have on dermalinstitute.com. You just might see this come up as part of our curriculum. And also, I wanted to let you know, is there anywhere, if somebody has additional questions, would you be willing to have some contact information? Would they be able to ask you any questions?
Yeah, absolutely. I'm very happy for anybody to reach out. You could email me directly. You could go Neilon. I don't know if you can put it in the chat from your end, Cecile, but it's S Neilon, Neilon, at dermalogica.com.
And I have put that into the chat if anybody has any other questions, because I know that we are running out of time and this is such a robust topic and everybody is interested in. So I just want to thank you so much again, Susan, for just giving us this great afternoon or morning in Australia of information. So can't wait to see what we come up with next, and everybody stay tuned for more information on dermalinstitute.com. Thank you so much.
Oh, thank you so much for having me on, Cecile, and thank you everyone for joining me. I really enjoyed it, and I wish you all the best for success for the treatment of both eczema and psoriasis.